Hey everybody, welcome. I'm Janak Goyal, and in this presentation I will talk about scanning techniques of knee joint. The examination of the knee is focused to the structures based on clinical impression, but for the purpose of learning and teaching, the sonographic examination of the knee is performed from 4 different quadrants: the anterior, posterior, medial, and lateral. Proper positioning is important for a good sonographic examination. For the anterior scans, patient is placed supine with the knee flexed by 20 to 30 degrees, and the dynamic scanning is performed with the quadriceps muscle contracted and relaxed to evaluate for a small amount of fluid, which could be missed by simple sonographic examination of the suprapatellar area. The knee is placed in maximum flexion for the examination of the femoral trochlea. Patient is placed in a prone position for the examination of the posterior aspect of the knee. Let's look at the anterior knee scans. The patient is placed supine with the knee flexed to 20 to 30 degrees. Longitudinal and axial scans are obtained on the suprapatellar and the infrapatellar location to examine the quadriceps tendon, suprapatellar recess, patellar tendon, and associated bursae. Probe is placed in the axial plane with the knee in maximum flexion to examine the femoral trochlea and the condylar cartilage. The distal part of the anterior cruciate ligament and its attachment to the anterior intercondylar area of the tibia may be visualized with the knee in maximum flexion. Here you have a long axis scan in the suprapatellar area. Patient is placed supine with the knee in 20 to 30 degree flexion, and the longitudinal scan is obtained by placing the distal edge of the transducer on the base of the patella. The quadriceps tendon is displayed as a 3-layered structure. The superficial layer is made from rectus femoris, the middle from vastus medialis and vastus lateralis, and the deeper layer from vastus intermedius. The suprapatellar fat pad is found just proximal to the tip of the patella, and the prefemoral fat pad just anterior to the femur, and the suprapatellar recess is found between 2 fat pads, and in the normal situation it usually appears as a S-shaped hypoechoic space. Scan the entire extent of the suprapatellar recess to have a good idea of the suprapatellar pathology, such as effusions and crystals. In this patient, the patient had a crystal-proven gout, and the image shows a significant collection of MSU crystal in the superior part of the recess, which is not seen in the immediate suprapatellar region. The dynamic scanning with the quadriceps contraction may be helpful to detect a small amount of fluid which may not be otherwise seen in the interior aspect of the suprapatellar recess. Here is a suprapatellar short axis scan. Patient is placed supine with the knee in 20 to 30 degree flexion, and the transducer is placed in a transverse orientation above the patella on the anterior aspect of the thigh, and the suprapatellar structures are evaluated on their short axis. Scan medial and lateral suprapatellar recesses to look for a small amount of fluid that may accumulate in these recesses and which can be missed by the midline suprapatellar scan. Squeezing the medial and lateral parapatellar recesses may be helpful to detect a small amount of fluid which has pulled in these recesses and is not present in the anterior prepatellar area. The femoral trochlea and overlying cartilage are examined with the knee in full flexion, and the quadriceps tendon assumes a curved course and is pushed anteriorly. Here is the position of the patient as a condyle, and here is the sonographic image of the condyle and the condylar cartilage, and here is the long axis image of the condyle with the condylar cartilage. For infrapatellar longitudinal scan, patient is again placed supine with knee in 20 to 30 degree flexion. Longitudinal scan is obtained by placing the upper end of the transducer at the tip of the patella and scanned towards the tibial tuberosity. Look for superficial and deep infrapatellar and prepatellar bursae. The mild distension of the deep infrapatellar bursa distal to patellar tendon is considered normal. Also examine the half-os fat pad, and we could look for the femoral condyle deep to half-os fat pad. Here is the infrapatellar short axis scan, transducer placed in transverse orientation to the patellar tendon. You could see the patellar tendon superficial structure like a sausage, and deep to the patellar tendon is half-os fat pad, and in a proximal part with the knee extended you should be able to see the femoral condyle deep to half-os fat pad. For examination of the medial side of the knee, patient is placed supine with slight flexion at the knee and external rotation at the hip. Identify and examine medial patellar retinaculum, medial collateral ligament, superficial surface of medial meniscus, and Pes Anserine tendon. Look for osteophytes on the femoral and tibial condyles and any bursa deep to medial collateral ligament, and also Pes Anserine bursa between medial collateral ligament and Pes Anserine tendon. For the examination of the medial collateral ligament, the transducer is first placed on the long axis of medial collateral ligament, oriented obliquely to the medial side of the knee joint. Medial collateral ligament is examined on its longitudinal and axial planes. The medial collateral ligament or the tibial collateral ligament is a broad flat band near the back of the knee joint, and it extends from the medial femoral condyle immediately distal to the adductor tubercle to the medial tibial condyle and the adjacent part of the shaft of tibia. It slopes anteriorly as it descends to the posterior medial surface of tibial shaft, where it is crossed by tendons of sartorius, gracilis, and semitendinosus. In this image, only the tendon of semitendinosus has been shown for the sake of simplicity and for the sake of showing the deep-seated Pes Anserine bursa, which would be hidden by the tendons of gracilis and sartorius coming together. For the examination of the Pes Anserine tendon, follow the medial collateral ligament on its long axis distally. The Pes Anserine tendon is seen crossing superficial to MCL distal to the medial tibial condyle. Rotate the transducer on the long axis of the Pes Anserine tendon and examine the tendon both in longitudinal and axial planes, and look for the Pes Anserine bursa located deep to the Pes Anserine tendon but superficial to the medial collateral ligament. The Pes Anserine tendon is a common attachment of the tendons of sartorius, gracilis, and semitendinosus, which is deep-seated at this point, to the medial surface of the tibia. The Pes Anserine bursa lies deep to Pes Anserine tendon and superficial to medial collateral ligament, that is the Pes Anserine bursa, is between the medial collateral ligament and Pes Anserine tendon. For the sonographic examination of the lateral aspect of the knee, patient is placed supine with internal rotation of the leg. The soft tissue structures seen on the lateral side of the knee from anterior to posterior are lateral retinaculum, iliotibial band inserting onto the Gerdy's tubercle on the lateral condyle of tibia, lateral collateral ligament extending between the head of fibula and the lateral epicondyle of femur, and the superficial surface of lateral meniscus, and the tendon of popliteus is seen in a groove deep to the attachment of lateral collateral ligament on the lateral epicondyle of femur, and the most posterior structure on the lateral aspect of the knee is biceps femoris tendon inserting on to the head of fibula. The iliotibial band is attached to Gerdy's tubercle on the lateral condyle of tibia, and it is located between the anterior and the middle 1/3 of the lateral side of the knee. The Gerdy's tubercle can be palpated on the lateral aspect of the upper end of tibia. Examined the ITB both in longitudinal and axial planes, and also examined the base of lateral meniscus located deep to ITB and check for any meniscal cyst which could be present at this location. For the examination of lateral collateral ligament, a patient is placed supine with the knee extended and leg internally rotated. Place the distal end of the transducer on the head of the fibula and orient towards the lateral epicondyle of femur, and examine the entire extent of lateral collateral ligament and its attachment to the lateral epicondyle of femur, and also notice the tendon of popliteus seen in the groove deep to the proximal attachment of lateral collateral ligament. And here in this video clip you will see the lateral collateral ligament, here the attachment to the lateral epicondyle of femur, here your popliteus, and you see the tibia and the lateral collateral ligament getting attached to the head of fibula. While maintaining the distal end of the probe on the head of fibula, shift the proximal end of the probe posteriorly to examine the biceps femoris tendon on its long axis. Both biceps femoris tendon and the lateral collateral ligament make a V-shaped attachment to the head of fibula. For the sonographic examination of the posterior knee, patient is placed prone with the knee extended. Longitudinal and axial scans are obtained on the medial and the lateral side of the posterior aspect of the knee. The structures seen on the sonographic examination of the posterior aspect of the knee on the medial side are semimembranosus, gastrocnemius, and the Baker's cyst if present. And on the lateral side of the knee you see the tendon of biceps femoris, plantaris, and the lateral head of gastrocnemius. The neurovascular structures, tibial nerve and popliteal artery and vein are located in the middle of the popliteal fossa. Here is a short axis scan taken on the medial side of the knee, and the scan shows the medial head of the gastrocnemius, and here is a small semimembranosus and gastrocnemius bursa. Here is your femoral condyle, and here is your semimembranosus. And in this drawing you see semitendinosus most posterior to the semimembranosus, and on the lateral side you see the biceps femoris tendon, and here is your the lateral head of gastrocnemius and the medial head of gastrocnemius, and here is the Baker's cyst projecting in a space between semimembranosus and the medial head of the gastrocnemius. Here is a long axis scan on the medial side of the posterior aspect of the knee, which shows the semitendinosus and semimembranosus muscle proximally and the medial head of gastrocnemius distally. Here in the scan, here is the medial head of gastrocnemius distally, and here proximally the tendons of semimembranosus and semitendinosus. The posterior cruciate ligament is attached to the posterior margin of the upper surface of tibia between the two condyles behind the posterior attachment of the medial and lateral meniscus, and to the lateral aspect of the medial condyle of femur. Here is a longitudinal scan of the posterior cruciate ligament showing the attachment of the posterior cruciate ligament to the tibia and here to the medial femoral condyle.